if the problem from an acid-base disturbance is coming from the bicarbonate side, which is metabolic. Okay, so bicarbonate is always the metabolic component of acid-base balance. The carbonic acid is derived from CO2, so it's always the ventilation component of acid-base balance. So we have two different components to consider when we look at acid-base. Is there a metabolic component causing the acid-base disturbance, or is it a respiratory disturbance causing an acid-base balance?
You wrote metabolic and then what'd you write underneath?
What's that, dear?
You wrote metabolic and then what'd you write underneath that?
Ventilation.
Ventilation.
Ventilation is derived from the carbonic acid because it's CO2 driven, right? The higher the CO2 times 0.0301 means that you'll have a higher carbonic acid level. So let's just do that just for fun. I know this isn't much fun, but kind of is fun. Okay, if your let's say your CO2 is 60 millimeters of mercury, and your bicarb is normal 24 milliequivalents, okay? So we've got a metabolic component of 24, we've got a CO2 of 60. We want to plug it into Henderson-Hesselbach and see what the resulting change in pH is. So to find carbonic acid, we take 60 times 0.0301. What is it? I'll do it a different color.
1.8.
1.8. So 60 times 0.0301 is 1.8. My bicarbonate is determined to be 24. 24 divided by 1.8 is what?
13.3.
How many?
13.3.
13 to 1. What would we expect the acid-base balance to be?
Acidic.
Acidic, that's right. Because it's less than 20. But more to the point is that that relationship is 13 to 1. So what's the log of 13?
1.1.
1.1 plus 6.1 is 7.2. So I have an acidic pH brought on by a metabolic problem or a respiratory problem, a ventilation problem.
Respiratory.
It's a respiratory problem. So this would be characterized as a respiratory acidosis. We've just defined the problem by looking at Henderson-Hesselbach, determining if it's the result of a problem with bicarbonate being metabolic or a problem with the carbonic acid being respiratory or ventilation oriented. Okay? So a 7.2 brought on by a CO2 of 60 is a respiratory acidosis. So let's talk about the different ways to categorize acid-base disturbances. Let alone from Henderson-Hesselbach point of view, although we could do that. There are, in fact, which one does the text talk about first? So I'll try to go right in line with how the text does it. So they do some Henderson-Hesselbach kinds of questions. They talk about the buffer system and the renal system. So the respiratory system in acid-base and the renal system in acid-base. So the first one they come to is respiratory acidosis. Okay. So in the human body with acid-base disturbances, what we'll generally do is initiate a problem with either the metabolic system or the respiratory system and compensate with the other. So in the case of a respiratory problem, we compensate by using the kidneys, and the kidneys help us to retain bicarbonate. So independent of the carbonic acid the sodium bicarbonate carbonic acid buffer system, that's one way to minimize pH change. We also compensate by the other system because we have both metabolic and respiratory components in Henderson-Hesselbach. Metabolic component is changed by how we make sense or how we compensate with the kidneys. Okay, so the metabolic system is all about kidney, either excretion of hydrogen ions or retention of bicarbonate. And the respiratory system is all about hyperventilating or hypoventilating to regulate pH change. So if we have a metabolic problem, we'll usually compensate by the respiratory system. If we have a respiratory problem, we'll compensate by the metabolic system. Okay? And that's why Henderson-Hesselbach describes so eloquently how we maintain pHs within 735 to 745 by maintaining a relationship of the balance between the kidneys and the lungs. The kidneys by bicarbonate and the lungs by carbonic acid. Is that we're always going back and forth. And it's kind of, I mean, I don't know how else to describe the pH system in that it keeps it within, we're able to maintain a pH within a fairly narrow range in the way that it's described physiologically. Otherwise, if the respiratory system failed, the kidneys would be widely trying to swing the pH back to within normal ranges. If it was the other way around, if the kidneys went out of range, the respiratory system would be constantly hyperventilating or hypoventilating, trying to keep it within balance. So we describe these numbers, these measurements, in very narrow ranges. pHs of 7.35 to 45, CO2s between 35 and 45 millimeters of mercury, and bicarb between 22 and 26 milliequivalents per liter. But Henderson-Hesselbach describes how we kind of maintain that equilibrium by maintaining a relationship of 20 parts to 1 of bicarbonate to carbonic acid, which is really the balance between the kidneys and the lungs. Okay. So in respiratory acidosis, or respiratory failure, like we said, respiratory failure, did I write it up here somewhere? Respiratory failure is when the PaCO2 is greater than 60. Oh, there it is right there. Respiratory failure, PaCO2 of greater than 60. In respiratory failure, we would expect a respiratory acidosis. Failure causes hypercapnia, right? CO2 rises because of respiratory failure. That's from a low respiratory rate, it's from a low tidal volume, it's from a low minute ventilation. It could be caused from any of the pulmonary pathologies you've talked about in pathophysiology. All of those things could bring on respiratory failure. And it's simply defined as a CO2 greater than 60. So in respiratory failure, what your body does is it tries to minimize the pH change by retaining bicarbonate. So in failure, if this is up to 60, then your carbonic acid is 1.8. The only way to bring that back into balance is to retain enough of this to make it 20 parts to 1 part. So if this is 1.8, then you have to raise the bicarbonate up to about 39 or so to normalize the pH. So in respiratory failure, the CO2 rises out of range and the pH goes down below 7.35. The only way to compensate for that would be for the kidneys to retain enough bicarbonate that it would swing it back to within normal. But you have to retain a whole hell of a lot of bicarbonate in relation to a little tiny bit of carbonic acid. Okay? So in respiratory failure, it's designated through an assessment of a blood gas. The results would indicate or would be characterized as respiratory acidosis. The way to compensate for that would be for the kidneys to retain bicarbonate. So we compensate for respiratory problems with metabolic compensatory mechanism. okay? The thing about the metabolic system is that it takes 24 to 48 hours for the kidneys to retain or excrete stuff from the urine, okay? At least 24 to 48 hours. So if we fail, you've got to fail for 24 to 48 hours before the kidneys are going to kick in. So usually what happens is we see a patient in the emergency room because the kidneys don't work that fast. So when a patient fails, they're done if they don't seek medical attention. pH is less than 7.2 for very long equals death. You know, some people can do it with diabetic ketoacidosis. So with diabetic ketoacidosis, that's a metabolic problem, and it causes an acidosis, but it's not. What happens is the bicarbonate goes way down. So let's just give you an example. The bicarbonate. Let's use this one right here. The bicarbonate HCO3 and the carbonic acid. If the bicarbonate goes down to 6, so instead of 22 milliequivalents, the bicarbonate is 6, and the body would recognize that already. It would recognize that there's an acidosis here because it's less than 20 to 1, and it would try to hyperventilate, and it would hyperventilate down to a CO2 of, let's say, 12. I'm just guessing, 12 times 0.0301. What is that number? 12 times 0.0301. It's about 0.36. That's what I thought. So what's the relationship of 6 divided by 0.36? What's that number?
16.6.
16, okay. So we're still, you can see, I've tried to compensate for that. And the interesting thing here is that when I had a metabolic acidosis, this is an example of diabetic ketoacidosis. So the metabolic problem was causing the acidosis. What did my body immediately start to do?
Hyperventilate.
It started to hyperventilate. So the human body was hyperventilating in response to this acidosis that resulted in a 16 to 1 relationship of bicarbonate carbonic acid. So in metabolic acidosis, I compensated by hyperventilating to minimize the pH change. So this could have been a whole hell of a lot worse if my CO2 was 40 and this was 1.2. Holy cow, this would be 3 to 1. Do you see the result that hyperventilation had on minimizing the pH change? But this is in metabolic acidosis. So in metabolic acidosis, the bicarbonate is the thing that's causing the pH change. What the lungs did to compensate was it immediately started to hyperventilate. So interesting part here is that the lungs compensate immediately. If there's a metabolic problem, the lungs will immediately hyperventilate or hypoventilate to try to normalize pH by Henderson-Hesselbach. If the respiratory system fails, it takes 24 to 48 hours for the kidneys to kick in and compensate. Okay, so that's the beauty of this system is that it does take a little bit of time for the kidneys to compensate. The lungs, however, compensate immediately. If there's an immediate acid load, I would start to hyperventilate in response to that right away. It would be disastrous if it took 24 to 48 hours for the lungs to kick in. So the lungs kick in and compensate immediately. The kidneys take 24 to 48 hours before there's an appreciable change in bicarbonate level. So this is a metabolic acidosis, and we compensate immediately in metabolic disorders by ventilation. So the lungs will hypoventilate. If I were to take, and we'll focus on this a little more next semester. If I take a big maybe I've got an upset stomach and I've kind of got an ulcer going on, and so I start popping Tums. You know what Tums is? Tums is essentially sodium bicarbonate. So it neutralizes the acid and it minimizes the pain and discomfort from an ulcer in your stomach. So if I took a roll of Tums for acid indigestion, trying to prevent the pain in my stomach caused by an ulcer, next thing you know, my bicarbonate level is 32. And I'm breathing normally here at 40. So my carbonic acid is 1.2. What's the relationship of me having just taken a bottle of Tums for acid indigestion, and as at least right now, there was this moment, I'm breathing normally with a CO2 of 40. What's the relationship? 32 divided by 1.2.
26.6.
So 26 is higher than 20. That's an alkalosis. So now I have a metabolic alkalosis, right? Metabolic alkalosis. How do I compensate for that metabolic alkalosis? I have to hypoventilate to raise the CO2. So in order to normalize a metabolic alkalosis, I have to hypoventilate to raise CO2 enough that this comes back out to 20 to 1.
So if you took enough of that, could you like stop breathing?
It's not probable,
Okay.
but you could take enough to interrupt your acid-base balance. You could become metabolically alkalotic, and you would try. Your body doesn't like to hypoventilate on purpose. It'll hypoventilate if it has to, but I've seldom seen a patient that has a metabolic problem, a metabolic alkalosis that brings on hypoventilation. We might do it a little bit, and theoretically it's possible, but physiologically we don't like to do it. So the message here is that we'll often compensate by the respiratory system with metabolic problems. We'll compensate from respiratory problems with metabolic compensation in the kidneys. Okay. So one of the questions this time, wasn't it, what's the acute compensatory mechanism of metabolic alkalosis? Was that the question, or was it the other way around? Something like that. The acute compensatory mechanism of respiratory, respiratory acidosis, I think it was. And the answer to the question is that there's no acute compensation of the kidneys. The kidneys take 24 to 48 hours. So in respiratory acidosis, if the CO2 goes up, the kidneys will retain bicarbonate over 24 hours. It'll take that long before you'll start to see an appreciable change in pH. So respiratory problems are particularly difficult because the kidneys don't catch up right away. It takes 24 to 48 hours. Okay. So the text kind of goes over information about respiratory problems compensated by metabolic or kidney retaining or excreting bicarbonate. Okay. So if the CO2 goes up, we should retain bicarbonate. That's the compensatory mechanism, is by matching this 20 to 1 relationship. So CO2 goes up, we have to retain bicarbonate. If CO2 goes down, we have to excrete bicarbonate in the urine. Okay? So in relation to respiratory problems, respiratory acidosis, we retain bicarbonate. In respiratory alkalosis, we excrete bicarbonate. All in an effort to maintain Henderson-Hesselbach relationship of 20 to 1. Okay. In metabolic problems, we end up with a high or a low bicarbonate, and we compensate immediately. There's an acute compensatory mechanism for metabolic problems, and it's through ventilation. So in metabolic acidosis, I'll ask you the question, will you excrete or retain CO2 or hypoventilate. In metabolic acidosis,
You will
Hyper.
hyperventilate. Yeah.
hyperventilate, very good. So if you have a metabolic acidosis, the compensatory response is to counteract that by hyperventilating, by lowering your CO2. In a metabolic alkalosis, we try to counteract that by hypoventilating and raising the CO2. That's a tough concept to get to, but that's really the relationship between the kidneys and the lungs, is the respiratory system and the metabolic system. Okay. What questions do you have? Anything from the text? I'm not sure if I can be a great deal more clear. Causes of ventilatory failure, that's respiratory acidosis. The nomogram on 320 is it's hard to make sense of because it's in 3D. It's a two-dimensional picture in 3D. So, and you've got different dimensions and planes here. CO2 across the middle, metabolic, alkalosis on top, acidosis on bottom, and then the bicarb either high or low on either side. So it's kind of a three-dimensional depiction of the relationship between CO2 and bicarbonate and what the resulting pH should be. Okay, 7.4 right in the middle. Anything higher than 7.4 is an alkalosis. Anything lower than 7.4 is an acidosis. So it's a tough picture to try to discern. Okay, respiratory acidosis on the case study. Take a look at those and see if we have any questions. Next week I'll probably entertain questions the first 30 minutes or so with CO2 transport. Okay. Because I think it deserves a little more information. But what questions do you have about what you've read so far? It's hard to put it together, I know, and you probably don't have specific questions right now, but if I can help, email me with questions, and we'll try to make sense of this. But CO2 and pH and bicarbonate then are the way that we assess through an ABG, acid-base balance, oxygenation, ventilation, and it really tells us how the human body is making sense of the relationship between the lungs and the kidneys, between ventilation and CO2 and bicarbonate. And Henderson-Hesselbach sets that up perfectly. That's the amazing thing is that it's a perfect way to describe the relationship between bicarbonate of 20 parts and the carbonic acid of 1 part. It tells us that the carbonic acid is much more important as far as any individual piece of acid-base balance. The ventilation makes up the most important piece of maintaining acid base because it only takes 1 part to change that pH, the overall pH. The bicarbonate needs 20 parts to have any appreciable influence. So the most important aspect of acid-base balance is the ventilation piece because it only takes 1 part to alter pH. Bicarbonate takes 24 to 48 hours to start compensating. The respiratory system compensates immediately. Okay? So when I use that word in the study guide, what's the acute compensatory mechanism of respiratory acidosis? There isn't one. There's not an acute compensatory mechanism because the kidneys, which would compensate for a respiratory acidosis, doesn't kick in for 24 hours or 48 hours. So we have...
For respiratory alkalosis.
Yeah, respiratory alkalosis, what would we do?
Hyperventilate.
Well,
or the kidneys.
Respiratory alkalosis is by hyperventilation. So what would the kidneys do? Acutely.
Get rid of the bite. There is an acute because.
Yes, that's the answer. So a lot of other students would tell me, Paul, you're being way too tricky on this one. That's a tricky question. I don't like tricky questions.
Well, the kidneys just take time. The
Yes, that's the take-home message is the kidneys take time. The kidneys don't compensate immediately. The kidneys will take 24 to 48 hours before it kicks in. So it's not a tricky question in my way of thinking. It's a way to get you to think about, and that's why I bring it up now, it's a way to get you to think about how the renal system interrupts respiratory disorders. It doesn't do it acutely, it does it over 24 to 48 hours. By contrast to that, in metabolic problems, the respiratory system does acutely compensate. The respiratory system kicks in immediately.
Would you rather have a respiratory problem than a metabolic, or a metabolic?
Yeah, in a manner of speaking, you would rather have a metabolic problem, a kidney problem, because your respiratory system could compensate for it immediately. Now, that's not always the case. I can't think of a metabolic problem I'd prefer to have,
Right.
because that means I have renal failure,
Yeah.
right?
Difficult to treat.
And renal failure is just, you want to stay away from renal failure if you can. Because it's interesting, isn't it, that renal failure leads to respiratory insufficiency or even cardiac problems. Because the way we've divided up the human anatomy in respiratory care is the heart, the lungs, and the kidneys, and the interrelationship of those three organ systems. So if we've got renal problems, you're going to get cardiac and pulmonary problems. If you have cardiac problems, you're going to get renal and respiratory problems. And if you have respiratory problems, you're going to get cardiac. I think I already said that one. Which one did I miss?
We know what you mean.
You're going to have trouble with the other two. So they all are interrelated. And the amazing thing about my graduate class is that they have now the experience to relate those three systems, and they've got 20 and 30 years experience that it makes sense to them, and they're understanding it on a whole new level. That's where we hope to get to. But we realize right now that this is a tough chapter, there's no doubt about it. You know, coupled with the oxygen chapter, man, there's some real deep anatomy and physiology. But that's really your bread and butter. That's where you become experts at the bedside about lung anatomy and physiology and its relationship to heart physiology and how that influences renal physiology. And understanding those three systems is what makes you a professional, a cardiopulmonary professional. Is how you understand and bring to bear the knowledge of what it takes to look at the interrelationships of those three systems. And that's where we are now. We're looking at heart and lung and kidney failure and its relationship to the other two systems. So keep pushing through. This is, you know, unfortunately in the baccalaureate curriculum, we just are allowed the time to scratch the surface. We could make a whole semester on acid-base balance and talk about the relationship of what's happening in the kidneys in metabolic dysfunction and what's happening in the lungs in respiratory dysfunction.
Do you have a whole semester on that in your master's program?
No, not even then. You're still using their knowledge and background to understand just on a deeper level what happens at this stage. So realize too, I don't expect you to be experts at this. I don't expect you to know the way I know it. I'm trying to explain it in a way that you'll understand it and you'll take it away, that when you see a patient that has a high bicarbonate and a low CO2, you can say that, oh, I know that the patient's compensating for the metabolic acidosis through respiratory compensation. Okay. Any other questions with? I'm just wondering if there's anything else in the text that I need to go through. We talked about buffer systems. We've done the Henderson-Hasselbalch equation. CO2. You can look at the clinical case studies. the way that the text divides it is by looking at respiratory problems with metabolic compensation. Okay, so respiratory problems either increase or decrease the CO2. We compensate by kidneys retaining or excreting bicarbonate. Okay, so taken by themselves, and I think the text eventually does this, is that if you look at respiratory acidosis by itself, respiratory acidosis, how would you compensate for that? The kidneys, would they retain or excrete bicarbonate? Retain bicarbonate in an effort to keep it 20 to 1. In respiratory alkalosis, the kidneys would compensate by retaining or excreting bicarbonate. Respiratory alkalosis. Excreting, why do you say that, Alicia? Excreting bicarbonate.
Because the pH is high, so therefore they want to release it to lower.
Yeah, so you release more bicarbonate to bring it back into the 20 parts to 1 part again. You're trying to reestablish that 20 to 1 relationship. So you excrete bicarbonate. That's exactly right. In respiratory alkalosis, you excrete bicarbonate. So going over to the metabolic side, in metabolic acidosis, do you hyper or hypoventilate? Metabolic acidosis. Hyperventilate. You try to counteract what the pH is doing. In an acidosis, you try to make the breathing alkalotic so that it balances the 20 to 1 part. And in, what's the last one? Respiratory metabolic alkalosis, we technically try to hypoventilate. Okay. So try to get the relationship of ventilation, hypoventilation in terms of acidosis and alkalosis, and what the resulting compensatory mechanism is in metabolic dysfunction. So in metabolic problems, we compensate through the respiratory system. In respiratory problems, we compensate through metabolic system, although not acutely. We only compensate chronically. So chronic hyperventilation. I think that's the question that I use. In chronic hyperventilation, what's the acute compensatory mechanism? Something like that. It was mixing up the term chronic and acute. And the answer was that there's not an acute compensatory mechanism. You don't do it acutely, you do it over time. So any questions with that chapter? We'll struggle with it, I think, for another week. The next chapter in the text is about ventilation perfusion ratios. Just look ahead and see. VQ ratios.
8.
Chapter 8. Holy cow. So VQ ratio should go pretty quickly. I can just give you an overview. Ventilation, if we breathe 400 milliliters 10 times a minute, what's the minute ventilation? 400 milliliters 10 times per minute. 4 times 10 is 4, right? So your tidal volume is 0.4 liters, and your respiratory rate, another name in the literature is they'll denote that as frequency. Okay, if you see that in the literature, you'll see frequency a lot. So if the respiratory rate's 10 breaths per minute, that's a minute ventilation of 4 liters. So V in chapter 8 is denoted ventilation. And a normal or an average ventilation is between 4 and 5 liters. So we're going to say 4 liters. So Q with a dot over it, in the Shunt equation, what did Q mean? What did you say, Alicia?
I'm just going to say perfusion.
Perfusion, yeah, in a way. In fact, the perfusion is equal to, in a manner of speaking, the amount of blood we send around through our circulatory system. So Q is cardiac output. So V with a dot over it is ventilation. Q with a dot over it is cardiac output. What's a normal cardiac output? About 5 liters. usually 3.5 to 5 liters. So if I've got ventilation to perfusion, 4 liters over 5 liters, I have a VQ ratio of a numeric value of 0.8. And it's just the number of liters of ventilation divided by the number of liters of cardiac output. 4 over 5 is 0.8. So VQ is a numeric value of 0.8. And the text just looks at ventilation, but what it does is it, going back to chapter 3 or 4 or one of those, remember we had 3 different zones of the lungs?
Yeah.
Zone 1, we have decreased ventilation. Zone 3, we have increased perfusion. And so we also have changes in our VQ. But what's interesting about ventilation and perfusion is that it's a numeric value that talks about what happens throughout all the lung fields. Even if you have, in this case, a left lower lobe pneumonia, what comes back to the heart here in the left atrium is really an average of what's gone on everywhere. Okay. So VQ does describe what happens up here, it does describe what happens here, it does describe what happened here. We can say that proportionally ventilation is up in the apical segments, perfusion is up in the lower segments, or if we look at it in terms of the whole relationship. So up here, what would VQ be in relation to the 0.8? If 0.8 is the overall average everywhere, to that 0.8, what's the relationship of the apical segments in terms of ventilation and perfusion? Yeah, the answer is that overall it's higher. Overall, the VQ is lower in the bases, and that's the crux of the chapter. It shows you that ventilation is high in the apical segments, ventilation is low in the bases, but perfusion is significantly higher. So VQ is lower in the bases than it is in the apical segments, and it just tries to explain that. But what happens in overall gas exchange is a relationship of overall ventilation to perfusion. Make sense? Ventilation to perfusion. Okay, well let's stop with anatomy and physiology.